So we'll continue where we left off and looking at rotator cuff disease. So let's go on and talk now about full thickness tears and some of the findings that we see in evaluating full thickness tears. And the things you kind of look for are fluid in the subacromial bursa, which is not specific, but very commonly associated with full thickness tears. Fluid in the subcoracoid bursa, fluid actually interrupting the tendon, proximal retraction of the muscular tendinous junction, as well as retraction of the distal end of the tendon, repair with scar in-situ, which we talked a little bit about, muscle atrophy, and rotator cuff arthropathy. So why don't we start here? Thomas, what do you think of this case?
So there's a large amount of fluid in the subacromial subdeltoid bursa, and the tendon looks near or almost full thickness tear of the supraspinatus.
When you say almost?
Yeah, it's full thickness.
Okay, how do you know definitively that it is full thickness?
Just because the tendon looks retracted, and
right,
and there's also, I guess, fluid.
So it's retracted here. Both the distal end of the tendon is retracted, and then if you look at the muscular tendinous junction, it's also retracted by about the same amount. So the only way you can get the whole tendon and the muscular tendinous junction to retract is if you have a full thickness tear. So you can say confidently that this is a full thickness tear, knowing that very rarely you can get scar in situ that we talked about last time, where you have a membrane here, which may make it a little bit difficult to see arthroscopically, but that's very rare, but just be aware that that can happen. And then we have all this kind of fluid in the subacromial subdeltoid bursa, which typically this amount of fluid is a little bit uncommon just in rotator cuff tears. What do you think about the signal intensity also within the subacromial subdeltoid bursa?
It's heterogeneous, so there's probably some hemorrhage there.
Okay. And there we can see the sagittal and axial images as well. And this is just a lot of subacromial fluid. This is more chronic. A lot of this is synovial thickening, which really comes from chronic disease. It's been there a long time. But this low signal intensity here is probably from more recent hemorrhage, rather acute hemorrhage. So it's really a complex situation of a chronic rotator cuff tear with a lot of chronic disease, as well as an acute superimposed upon the chronic disease of the subacromial subdeltoid bursa. Okay. Let's see, Pablo, what do you think of this case?
Let's see, I have sagittal views, two sagittal views. Let's see. So I'm looking at the greater tuberosity there, and I see the deltoid, but not. There's a fluid signal intensity right there in the anterior. I think it's the anterior aspect right there, that pocket there.
So what is that?
I wonder if that's full thickness tear of the anterior fibers of the supraspinatus.
So why do you wonder? Why don't you just say it's a full thickness tear?
Well, I would just like to follow the tendon maybe in the sagittal planes, do other images, make sure that's
this is a sagittal plane. That's really all you see. You can certainly look at the coronal plane.
Coronal,
there's something else here that is highly correlates with this being a full thickness tear. What else do we have here?
There's fluid in the subcoracoid bursa.
Right. So here's fluid in the subcoracoid bursa. Now, this bursa is separate from the subscapularis bursa, which is just up here, which is a continuity of the joint of the glenohumeral joint space over the subscapularis muscle. The subcoracoid fluid is in front of the subscapularis muscle, and this communicates with the subacromial subdeltoid bursa in most people. And if you have a small amount of fluid in the subacromial subdeltoid bursa, it tends to pool down in the subcoracoid bursa. And then what this lets you know is that there is fluid going through the tear here into the subacromial subdeltoid bursa, though we don't see it there, but it's collecting in the subcoracoid bursa. And this is highly associated with a full thickness tear. So fluid in the subcoracoid bursa can be helpful in letting you be much more confident that you're dealing with a full thickness tear and just not a partial tear. So that's a supraspinatus tear, and that shows how the subcoracoid bursal fluid can be helpful. And here's an example where we can see fluid in the subcoracoid bursa here, which actually goes up and communicates with the subacromial subdeltoid bursa. And here you can see where the subcoracoid bursa is separate from the subscapularis bursa. This is the joint capsule. This is joint fluid here. This is fluid outside the joint, which is in the subcoracoid bursa, which comes down in front of the subscapularis muscle. So this is indicative that you're probably dealing with a tear, or either that or pathology of the subacromial subdeltoid bursa, and this is just fluid in the joint space. So that's those sometimes can be helpful.
Okay, two coronal images of the shoulder. It looks like there's a full thickness tear of the supraspinatus tendon retraction.
Okay. What else do we see here?
And it looks like there's fluid in the subacromial subdeltoid bursa, and
maybe a little bit here coming into there. What's this fluid down here?
I'd like to see a sagittal for that. And it's back there. That's posterior, right? Or is that anterior?
Well, this is right in front of the humerus, right?
Yeah.
This is anterior.
Okay, that's anterior. So in that case, it could be in the subcoracoid recess.
It could be in subcoracoid, or it could be in the biceps tendon sheath. You have to just check and see which is in here by looking at other things. In this case, that was a subcoracoid bursa. And on the sagittal images, we can see that typical tear of the anterior insertion of the supraspinatus tendon on the greater tuberosity. Same location as the previous. This is a high field study. The other one was a low field study. And then here we can follow the fluid going through the tear into the subacromial subdeltoid bursa, and down we can follow it tracking all the way down into the subcoracoid bursa. So that can be helpful.
That bursa is immediately anterior to the biceps tendon too?
It's anterior to the subscapularis. Mm-hmm. It's usually, generally it's not right next to the biceps. Mm-hmm. Yeah. Okay, Thomas, what do you think of this case?
So there's some susceptibility artifact, probably from a prior cuff repair.
Probably, or something surgical. The cuff looks pretty native here, so I'm not. But
yeah, so maybe that's not from a cuff repair.
Well, it may be too. We'll have to see some other images here.
But the cuff itself looks in continuity.
Supraspinatus here, right? Okay.
Yeah, but there's some fluid in the subacromial subdeltoid bursa, okay, and also
here. And notice how different. Well, so what's happened here? Do you think?
So I think there's contrast in the subacromial subdeltoid bursa that's not communicating with.
Looks like somebody might have stuck a needle here, maybe. Here we can see this is very bright on the. This actually is a T1 fat suppressed image, much brighter than the fluid actually in the joint space.
Right. So they administered the arthrogram to the subacromial subdeltoid space.
Right. So this is a subcoracoid injection, and you have to be careful of this because most people now use an anterior approach, where anteriorly you will actually go through. This is much more lateral than typical. Typically, you go an external rotation. You do an anterior approach where you go through the subscapularis tendon. And when you go through it, you also go through often the anterior aspect of the subacromial subdeltoid bursa in that space. And you often get a little bit of track of contrast through there, which means you can get contrast into the subacromial subdeltoid bursa even with a good injection. This happened to be an injection which was primarily in the subacromial subdeltoid space rather than the glenohumeral joint space. So now, as many of you know, I'm not a big fan of doing arthrography. And one of the reasons I'm not is the fact that there is a lot of pathology here anteriorly, and that's right where you stick a needle. And sometimes the contrast can obscure findings such as acute tears of the subscapularis, and as well as sometimes you can damage the anterior labrum if you're not careful. But anyway.
This injection is below the surgical neck.
Below the well, why do you say that, John? This is
What's all that fluid down below on the left
over here.
image?
Oh, this is fluid that extravasated down in the subacromial subdeltoid bursa, and it just extravasated distally. The injection itself was up here higher, but they forced contrast under pressure into the subacromial subdeltoid bursa, and it decompressed distally into this area.
I got it. It's okay.
And then here we can see this is all contrast down in through here inferiorly, right where you were concerned about.
Yeah, that's a peculiar injection.
Yeah, we hope not to see too many of these.
Would be painful too.
Yeah, it might have been. I don't remember the symptoms in this patient, but you're probably right. Okay, here's another case. This is a patient who had surgery, and here we can see some fluid in the subcoracoid bursa. And one thing to remember is once you have surgery around the shoulder, and just about any kind of surgery that involves the capsule or the rotator cuff, you don't always get good seals afterwards, and it's common to get, even if you have a good injection, you can get contrast which extravasate in the subacromial subdeltoid and subcoracoid bursa, even if you don't have a tear of the construct. So once you have surgery, the location of the contrast, just because you have contrast extending into the subacromial subdeltoid bursa, does not necessarily indicate that you've got a recurrent tear. So you have to be careful with that and not overcall it. You actually have to see the tear of the construct before you can call a tear once you've had surgery, because it's typically not watertight. And we can just see joint fluid going through a tear into the subacromial subdeltoid bursa, typical of a full thickness tear. And here we can just see it on the sagittal images, the tear and then the fluid in the subacromial subdeltoid bursa. And here's kind of a chronic full thickness tear where we can see proximal retraction of the tendon. Notice here that there is more loss of the distal tendon than there is proximal retraction of the musculotendinous junction. That can be due to a couple of things. If the tear is small, you might see a big fluid collection here, but enough the tendon is still intact that you don't get retraction of the musculotendinous junction. Or it could be due that you just have a lot of disintegration of the tendon, but still the tear is small enough where you don't have a proximal retraction. And here we can also start seeing some rotator cuff arthropathy here. We're starting to see degenerative disease of the inferior surface of the acromion process.
Would that concern you as far as stability is concerned? That last slide.
All right, here, as far as you mean stability of the humerus?
Joint, glenohumeral joint.
Well, it concerns me once you get large supraspinatus tendon tears, you start getting superior migration of the humeral head, which is probably...
Yeah, the deltoid is atrophied.
Yes, and the deltoid, yeah, that's a good point, John. I'm glad you brought that up, is that atrophy of the deltoid is also very important because it's a very negative prognostic factor if you see atrophy of the deltoid.
Yeah, this is a bad news shoulder. I don't think I would know how to fix it.
Right. And there we can just see the tear in the sagittal plane. Okay. Pablo, what do you think of this case?
So it's a T2 sagittal image. Let's see. Looks like I don't see very well the supraspinatus muscle. I see what I think is the little anterior. Okay, I see. That's okay, and I see some fluid in the subacromial subdeltoid bursa, and there's a focus that is hypointense. Well, it could be blood, I guess, or it could be also a calcification. Axial image. So again, shows fluid, and I think we can see it with a little more intensity, hyperintensity, that focus there. Yeah, right there, so anteriorly.
The plane is right through here. So what is all this stuff, which is this stuff?
I wonder if it could be part of the tendon, that it's kind of bended or retracted, and
so the tendon is torn here.
Okay.
What's happened is the anterior part of the tendon has kind of displaced anteriorly, and we were just partial volume.
Partial volume.
So sometimes you can get some funny looking things due to the displacement of tears of the tendons. And here we can see some proximal retraction in the area of the tear, a little bit of retraction of the musculotendinous junction. So supraspinatus tear. And this just shows, now here's an arthrogram. So they did an arthrogram looking for a rotator cuff tear. What's funny about this arthrogram in someone who has a rotator? We certainly see the tear, but what's funny about the arthrogram in this case?
It looks like there's no communication with the subacromial subdeltoid bursa.
So what we're seeing here actually is fluid is going through the tear, but it's not really freely extravasating into the subacromial subdeltoid bursa. Notice this patient is an athlete, the well-developed musculature. And what can happen with these is that you can get scarring overlying where the tear is, and we may not see it as dense scar in situ like we saw before, but it can wall off the space here, and you won't get free communication into the rest of the subacromial subdeltoid bursa. So just be aware that anything that can happen will happen at some point when you're doing things, and don't be too confused if every tear doesn't read the book.
And that didn't have anything to do with the patient having well-developed muscles. It's just random scar.
No,
or it does have to do with big muscles.
It probably means that it's chronic, and the patient is able to scar, and he probably has enough stability with the scarring that we really don't see here, that we're not getting a whole lot of retraction, and he still has good muscle development. So there's probably enough scar stability from the scar that his supraspinatus is still somewhat functional here. Okay. Thomas, what do you think of this case? Oh, wait, let's see. Let's see if, I'm sorry, Sahar, what do you think of this case?
Okay, so we have two coronal and one sagittal views of the shoulder, and there is like traction cystic changes in the humeral head at the attachment of the supraspinatus. I don't see any definite tear in the supra.
Okay, so now you say you don't see a tear. Why do you say you don't see a tear?
So maybe there is some superior migration of the humeral head. Maybe there's some scarring in place. So
where's the musculotendinous junction of the supraspinatus?
it looks like it's at the level of glenoid, or maybe even more
back here, right?
Yeah.
Where's the distal end of the tendon itself?
About here, like at the glenoid AC joint, somewhere around there.
Probably right there. So what's all this stuff here?
Scarring.
Yeah, so this is our scar in situ. So the last case had some scarring, but it was pretty minimal. It just walled off the contrast. This is dense scar in situ here. But you know it's a full thickness tear because the musculotendinous junction has been retracted by about 4 centimeters. Remember, the musculotendinous junction should be around the 12 o'clock position. And this is the end of the tendon. We can see the abrupt change in the signal intensity, and there's a little bit of fraying of the distal end of the tendon. This should be attaching to the bone here, and this is all scar in situ in between here. And look how it almost looks like a normal tendon on the sagittal images. But you know definitely this is torn because of the retraction. The other time you could see this is if a surgeon goes in and has a tear that they can't actually repair. And there are some procedures if the patient has symptoms where they'll put what's called a graft jacket, and there are a bunch of other names, which is basically usually some sort of a fibrous sheet of tissue that they'll sew into place up here. And we'll get to that when we talk about the surgeries of this particular area, which tends to buffer and keep direct bone-on-bone articulation here of the acromion process. The person who has a lot of experience with this, probably Sahar, is going to be Greg Applegate. You might ask him how long those graft jackets stay around, but I think they can stay around for quite some time. And some people who have massive rotator cuff tears that can't be repaired can get some symptomatic relief from that. But one of his surgeons, Steve Snyder in the Valley, popularized that particular surgical technique.
When someone develops that much scar,
yeah,
do they become less symptomatic? Does the scar sort of act as a
that's the idea. Is to get rid of the pain. You wouldn't operate on these end stage problems unless they were not painful. If they were not painful, you wouldn't operate on them. These can be so painful that people need narcotics.
So I don't know if they have a lot of scar inside too, whether they'd be less symptomatic if they didn't. Maybe I don't know. Also, but the one thing to remember that this scar tissue does have a lot of nerve endings in it. So I'm not sure. But
well, you're not you're kind of free of pain most of the time, right?
Yeah, absolutely. And
well, there you go. You have the scar inside too.
There you go. So it can help. At least in my case, it helps. I don't have quite this much of it, yeah. But that's right. Good job. Okay. So who's next? Oh, Tom. Thomas, what do you think of this one?
Okay, so we have a 59-year-old male, persistent pain after surgery, and it looks like maybe they might have had a cuff repair, but there's some atrophy of the supraspinatus, some retraction, and I think it looks like a full thickness retear of the supraspinatus.
Okay, so right. So what we're seeing here, there's the proximal retraction of the musculotendinous junction. Now, sometimes when they do the repair, they don't bring the tendon all the way back. You know, like to, but sometimes you can't. And so this is probably tendon here, but in this particular case, this high signal intensity material here is almost certainly not tendon. This is all probably scar in situ. And we can see that there's fluid anyway going into the subacromial subdeltoid bursa. I don't remember if this is an arthrogram or not. But again, after surgery, that's not very helpful to us. But because of the proximal retraction, and we actually had an MR scan before that I should have here that actually showed that musculotendinous junction was in the normal position after surgery. This was all a tear of the surgical construct with retraction. And the position of the musculotendinous junction can be very helpful. This also extended posteriorly into the infraspinatus tendon, and we can see retraction of the infraspinatus musculotendinous junction as well. That's the distal end of the infraspinatus tendon, and this is all scar in situ coming up over the top there. So scar in situ is fairly common, and you shouldn't misinterpret it as not torn. This is clearly separate from the tendon, and this is a dense scar in situ. Okay, Pablo?
See, we have two coronal images. So the humeral head is elevated, the subacromial outlet is narrowed, so there's no supraspinatus tendon, or there's retraction of the musculotendinous junction consistent with the full thickness tear. There is also fluid, it looks like in the subacromial subdeltoid bursa, a little bit in the joint 2 space, and there's some remodeling, I think, of the acromion under surface. Okay, okay, so there's a hypointensity there. Now I think that's the one of the tendons, probably the supraspinatus tendon, that it's displaced into the joint.
So that's the other thing you need to look for when tendons get in spaces where they're not supposed to be. That can be a problem, and we'll talk a lot of other areas in the musculoskeletal system, like the fingers and elsewhere, where displacement of tendons and ligaments can lead to symptoms or abnormal healing, and may be an indication for surgery. And this patient also obviously has superior micro.
The only thing you can do with this one would be just about a total joint replacement.
And
or if in the old days we used to do fusions.
Wow. And then we can see there's superior migration, direct articulation with the humeral head and the acromion. Then rotator cuff repair, not very successful.
No, not even, I wouldn't attempt it.
And then we can see a lot of edema here. This patient actually had a recent acute injury with bone injury. And then the deltoid, again, is very atrophic. So you need to mention all of those in your report.
This is not operable except for a total joint.
Yeah.
Reverse.
Yep. Okay. All right. So what do you think here?
All right. 66-year-old woman fell 10 days ago, can't move arm. So it looks like we have a full thickness tear of the probably supra with tendon retraction.
This may be infra coming back.
Or infra. Trying to make sense of the two images on the right.
So there's a lot of soft tissue injury here. The distal end of the tendon again has subluxed into the glenohumeral joint space.
Similarly, yeah, it looks like subluxation of the distal tendon. Wow.
And a humeral head.
Yeah, and the biceps is torn. So there's a lot of disease here, but the main thing here is this is another case where the tendon is displaced into the joint space. Okay. Let's see, Sahar, what do you think of this case?
Okay, we are showing an arthrogram. Now the contrast is going to the joint space, and I think it's going to the subcoracoid bursa as well. So there might be a thickness tear.
Some probably in the up here. Yeah, I'm not sure. I think this is glenohumeral joint space here. Obviously, the patient can't have an MR at this time because of a pacemaker.
Mm-hmm.
There we can see contrast going to subacromial subdeltoid bursa, so there must be some form of a tear. So what occurred here?
So we see the contrast going to the subacromial subdeltoid bursa.
What kind of study is this?
This is CT arthrogram.
Yeah, good.
Yeah.
And then we see the big tear there.
Yeah, there's a full thickness there.
So you can do CT. Now, as a lot of you probably know, the current feeling is that all modern pacemakers can go in an MR scanner. So having a pacemaker, unless it's a really old one, and to be quite honest with you, even the really old ones probably aren't a problem in the scanner, as long as you have someone there who is able to monitor it, and if an arrhythmia occurs, be able to treat it. In the early days when we were evaluating the cardiovascular disease with the early MRs back in the late 1980s, we were checking to see if how much power people could absorb without overheating. So we did a lot of studies looking at thermophysiology in an MR scanner. And we did a lot of early MR of the cardiac disease, and it just turned out we shouldn't, somehow we ended up scanning a number of patients with pacemakers that we didn't know had pacemakers. And we had no problems with any of them, and none of the pacemakers were damaged. So I've always been skeptical of the people being adverse to doing pacemakers in a scanner. And now a lot of them have been studied. Recent studies have shown that they're basically all safe. And for ultimate caution, though, it's recommended that you only do people if you know that they have a pacemaker that's a modern pacemaker, and you have someone available at the scanner who can treat arrhythmias and advanced life support in case it's necessary. It generally means that those patients need to be scanned in a hospital out of caution. Okay, Thomas, what do you think of this case?
Before you answer, do low field scanners, are they a little less dangerous?
There's been a lot of debate about that, and the general feeling right now is the low field scanners probably aren't any safer than high field scanners when it comes to electronic devices in the scanner. And it actually depends on the specific electronic device, and has to do with the frequency of the RF that occurs. And some devices handle the higher frequencies better than lower frequencies. But the bottom line is that in most cases, there's not really a clear difference between high field and low field when it comes to risk for electronic devices.
Got it, because they're in the scanner longer. Okay.
They can be.
Thanks.
Okay. Thomas, is this yours?
Yes, so the supraspinatus looks like it's intact. There's a little bit of thickening of the subacromial subdeltoid bursa, and then there's some edema at the greater tuberosity, and I'm not seeing any cortical disruption.
Well, I wouldn't say no cortical disruption. I think the abnormal signal goes up to the cortex. So what? So you can have rotator cuff tears, but the other thing, especially in younger individuals, you can have is that you can have the same symptoms as rotator cuff tear, but it's because you have an avulsion injury of the greater tuberosity. And these are fairly common in trauma to teenagers and young adults. And I think this might have been my son who had a bad fall skiing, and I think this was due to a skiing accident. Okay, so let's go back to something we saw quite a few lectures ago, and that is Richard Hawkins, who was a well-known shoulder surgeon. Said there are basically 7 things that he wants to hear in every MR report on the shoulder, especially when it comes to rotator cuff tears. And size, quality of tissues, location, fatty infiltration, elevation of the humeral head, acromial morphology, and status of the biceps. So let's now talk about, we've talked about the size and the quality of the tissues and location. Let's talk about fatty infiltration. So, and there are a couple of these that are important. If you have a lot of atrophy and fatty infiltration of the muscles, those patients do not do well with primary repair, and they can actually do worse after surgery. So that's a relatively strong contraindication for doing rotator cuff repair. So that's why we're primarily going to talk about it. The elevation of the humeral head we just saw, that's also people with superior migration of the humeral head are very poor candidates for rotator cuff repair. And that's when John was saying that they really should have that patient should have had a joint replacement, not a repair of the rotator cuff. We've already talked about acromial morphology. So let's talk about fatty infiltration. So atrophy of the supraspinatus tendon is a strong negative prognostic factor when it comes to surgery. So you can see decrease there. One way of evaluating this is look at the sagittal images for looking at decreased volume on the sagittal images. This is a so-called tangent sign. And the other thing we look for is increased fat. So if you do the tangent sign, you do a sagittal image, it's a little confusing, like this. And the normal supraspinatus tendon should be sitting right here, superior to the scapula, anterior to the acromion process, and the superior margin of the supraspinatus muscle should go superior to a line drawn between the anterior margin of the scapula and the superior margin here of the acromion process in the Y view. And a positive tangent sign would be that that's not the case. So I want to point this out just to strongly recommend that you not use this sign. And the reason it's not good is that, let me see. Well, let's go to the next case. Who has the next case? Who did the last case? Pablo, why don't you do it? So what do you think here, Pablo?
Let's see, 66-year-old male with pain after acute trauma, and there's a sagittal T2 plane, and there's it looks like this is south of that line, the supraspinatus muscle, but this could be due to retractions.
Okay, so here's a positive tangent sign. Now let's look at the tear. So he's got a big supraspinatus tendon tear, right?
So there's full thickness tear and retraction, significant retraction of the musculotendinous junction. So probably the sagittal cut was at the level of the musculotendinous junction.
Okay.
This way.
So if you look here, the distal end of the supraspinatus muscle is a cone. It has a point here where you have the musculotendinous junction, and then it gets larger more proximally. So if you have an acute tear like this one was, and you get proximal retraction of the musculotendinous junction, and if the plane you're looking at is right through here, what will happen is you may not have significant atrophy of the muscle. You may have a quite normal muscle, and in an athlete it may be a hypernormal muscle. But what you have is retraction of the muscle, so you get a positive tangent sign even though you do not have any atrophy of the muscle. And these are the patients who are at best risk for doing rotator cuff repair, because the muscle is normal. They're often athletes that have trauma. They have relatively normal tissues, though there's a little bit of degenerative tissue here of this cuff. So this is someone who had a tangent sign but has no muscle atrophy and is actually a good candidate for doing a repair. So just remember, proximal retraction can produce a positive tangent sign in someone who still may be a good candidate. So
can that muscle be contracted like in spasm, John?
Yes, and I'm sure it can, John. Which would cause it to retract.
Okay, 77-year-old female with acute injury and shoulder pain. So it looks like a positive tangent sign here. I'd want to see the coronal images. So it doesn't look like, oh, I guess there's a little bit of fatty atrophy. There's a full thickness tear, but not as much as the sagittal would suggest.
So it's another case like that one. This is an older individual, positive tangent sign, but not much atrophy. So the other way to try to evaluate atrophy, which I strongly recommend you use, is looking for the amount of fat in the muscle. And there are 4 stages. And basically, if you have equal amounts of fat in muscle, or more fat than muscle, those patients are poor surgical candidates. If you have more muscle and fat, then they're still good candidates for surgery. So here's an example. Here's a tear. We can see the proximal retraction. Definitely a positive tangent sign, but on the coronal images here we have quite a bit of fat within the muscle. This is probably stage 2. There's still more muscle than fat, so that patient, just on the basis of the way the muscle looks, still may be a candidate for surgery. Okay. Here's another example. We can see the patient already had a rotator cuff repair. Here's the suture anchor. There's been a tear of the construct, superior migration of the humeral head, proximal retraction, and here we have pretty much about the same amount of muscle and fat, and this would be stage 3. For various reasons, this patient is not a good candidate for re-repair. Too much fatty atrophy. And the reason why this is a problem isn't because of the fat or the fact that the muscle is weak. The fact is that if you get fatty atrophy of the muscle, in with this fat gets a lot of fibrous tissue, and that muscle is no longer pliable. It becomes very rigid, and you can't pull it enough. It's not flexible enough to allow you to pull it up here and get a good repair. If you do it and there's too much tension, it'll just pull out your repair. That's probably what happened in this particular patient. So really, this is a surrogate marker for fibrosis within the muscle.
It becomes stiff.
Yeah. Okay, what do you think here?
75-year-old man, single suture anchor repair 3 years ago, placed at base of greater tuberosity because the tendon could not be stretched. So it looks like I see a retraction of the suture anchor at the level of the glenohumeral joint, and probably fatty atrophy of the supraspinatus. Or did it go right through the...
This is actually where they placed the suture anchor.
Okay, so it looks like it came right out.
Yeah, but the actual suture anchor was placed over the articulating cartilage of the humeral head. Here, that's where the suture anchor was placed. Really.
This was done by a medical student.
So here, the suture anchor is actually placed through the articular cartilage.
Huh.
So, if you can't stretch it out here to repair it at the normal, remember what you're actually doing with suture anchors is you're stabilizing the placement of the cartilage next to the bone. You roughen up the bone, and then you want the bone to grow into the cartilage so that you get a biological repair, because the suture anchors don't last forever. So the suture anchor is just there temporarily to allow you to get biologic healing. This is obviously in an abnormal position. This, even if it heals, the patient's not going to have normal motion of the shoulder. It doesn't make much sense to put a suture anchor in that location. And this one still pulled out. But that's because this patient had a very stiff muscle. We don't see the...
What I like to do is make a trough where the foot plate is, and then use that as a place to tack down a tendon or tendons.
Yeah, up by the foot plate up here. Right.
I don't just roughen it up. I make a trough there.
Good. That's pretty good. Okay. All right.
It's like First World War.
Okay. And then here we can see this is...
Ditch it.
John, what did you say?
Just like the First World War, those ditches they used to make.
Right. Trench warfare. So
trench, right.
You practice trench warfare in the operating room.
That's a good example for the surgery that I would do. You make a trench and then you pull the tendon into it. I never had a problem with that.
Good. Okay, and here would be stage 4 fatty atrophy of the supraspinatus muscle, obvious retracted, chronic disease, and we can see chronic superior migration of the humeral head, bone-on-bone articulation, marginal osteophytes, denudation of the articular cartilage. Obviously, this is severe disease. On the coronal images, we can see severe fatty atrophy also of the deltoid, as well as the infraspinatus and the teres minor. So, stage 4 disease. Oh, damn it, I forgot to do this. Okay.
Total joint.
Okay, so this is fatty atrophy. Sorry about this. I'll go ahead and say. So, but this is very diffuse disease, severe atrophy. So what other things do you think about besides the fact this patient had a rotator cuff tear? In this particular patient, the next thing we did was an MR of the cervical spine, because what we found here is there's severe central atrophy. Central stenosis, and this patient had neuropathic disease involving all of the shoulder joint muscles, and that was the cause of the fatty atrophy. Yeah. Shoot, I blew my own punchline here by not giving this. That's right. Okay. So if it's very diffuse disease, think about other things that may be the culprit. In this case, it was a cervical spine. Okay, so then we talked a little bit about elevation of the humeral head. Here's just another example where the humeral head is elevated, direct bone-on-bone articulation. These patients do not do well. So then we can talk about surgery. So now with the era of arthroscopic surgery, there are a whole host of different techniques for doing repair of rotator cuff tears. Since now we see that the vast majority of tears that we know both from MR and from arthroscopy actually come from avulsion off of the bone, that the typical surgery is to put in a suture anchor, put the sutures around the tendon, bring the tendon back again, roughen up the surface, put in a trough, whatever, and you want to try to stimulate a healing between the tendon and the bone. And the suture anchor there hopefully will keep it in place long enough for that biologic repair to occur. So that's the concept behind it. You can have a single row technique like this where you just bring it down and have it set. The issue with this is that in order to get the best repair, you would like to have as much of the tendon adjacent to the bone as possible so you can have a broad area where the tendon and bone will adhere to one another. This is a little over a centimeter in this area. And here we can see this is an example of a tear, fluid going into the subacromial subdeltoid bursa, put in a suture anchor, brought the tendon down, it fixed the tear, and then you want biologic healing to occur over the next 6 months. And this is a sagittal image showing a small tear. The suture anchor and the tear is now repaired, and hopefully it'll scar in and have good healing. Now, another technique that's designed to try to increase the cross-sectional area here where the tendon stays next to the bone to get maximum healing is called a double row technique. And again, there are a number of different ways to do this, but primarily this is the tear before surgery. Here's after surgery. You put in a row of suture anchors approximately just peripheral to the articular cartilage. And then you put another suture anchor row distally. Now this one is right next to the foot plate. Often now the distal row will be about a centimeter farther down. And then you'll tack down the tendon by mattress sutures or several different techniques to try to get uniform pressure of the tendon against the bone here over the entire foot plate area, where your construct tacks it down both medially and distally like this. And we did a study a couple of years ago where we looked at the difference, and we found in larger tears there was a better outcome by using MR at 1 year when a double row technique was used than when a single row technique was done in randomized patients. Not every study that's been published has shown that. Some other studies have shown that there's really no difference between the two techniques. But our study showed that there was.
Is that fluid normal there between the tendon and the suture?
Right in through here?
Fluid, yes.
No, you'd like not to see that fluid there. So there we can see. And then that just shows the tear. And
can you pull that back, John?
Yes.
That last.
Yeah.
That doesn't look like it's all
adherent right here.
It looks to me like it's still torn.
Yeah. What we can see is that the tendon's in a little bit better position here, but I agree. This was a arthrogram injection, and we see contrast extending into the area where we really would like to see a good repair. So this was not considered a successful technique.
Yeah, what you really have to do is not think about using double row, triple row, or whatever. Is use what you need to tack down the tendon and get a good fixation. Everything depends on the fixation, and make sure that the muscle isn't really being pulled real hard. If it's difficult to pull the muscle into the tendon into position, you're going to have problems. Then what you do is you abduct the arm, but if you abduct it, you cannot go too far. The sutures will still pull out. And the abduction split will be maybe 45 degrees in abduction, and you have to keep that on for 3 to 6 weeks. It can work out, but it's going to be quite an effort.
Okay. All right.
But I don't think one can come out with a statement, use so many rows, because each shoulder is different. I don't mean to saying bad about double row, because I never done that, but you use as many rows as you need.
Yeah, well, the concept was that you create a larger interface between the bone.
Oh, I understand that.
And therefore,
what I mean is that if you need one's
what we showed in small tears, the double row was not beneficial, which would go along with what you're saying, John. In larger tears, the double row technique was beneficial.
Right. It all depends on how much tendon you have.
Right. Okay. And here's just a case of a surgical technique. This is an old double row technique. The patient was actually doing well. He had some symptoms due to something else, actually, and it just shows that the surgery, the construct is intact. But even though the surgical construct is intact, we can still see contrast extending into the subacromial subdeltoid bursa. So once you have surgery, commonly it is not watertight, even though you have an intact tendon. The other thing that you can see after surgery, here we have this case of surgery. Oops, why is it doing that? We can see that there's proximal retraction of the musculotendinous junction. It's nice and dark all along here, but this is actually a tear with scar in situ. So this is not an intact surgical construct. What will often happen with these is that they'll tear, they'll start to retract, then you'll get scar tissue forming. It'll tear a little bit more and retract more. And as it retracts, it develops scar along here. And so you end up with a dark line all the way from the distal end of the tendon to the insertion point, but the muscle has retracted and the construct is not mechanically intact. This is really the distal end of the tendon here. This is all scar in situ. So remember that you can get scar in situ after surgery as well.
It looks like sutures were put distal to the greater tuberosity, right. And that's not going to fly, because that's too much tension on the muscle and tendon.
Yeah, but a lot of the techniques now will put the suture anchors a centimeter distally here, and the sutures will come back and attach to the tendon itself, but the tendon stays here at the foot plant.
I haven't seen that.
Okay. And then here is a tear. Here we can see a clear tear with contrast going in and separation of the tendon. And here's another tear. This is on 11/17/07. We can see the tear, proximal retraction, fatty atrophy of the muscle, superior migration of the humeral head. A lot of atrophy here, both the supra and infraspinatus tendons torn. They then put in suture anchor repair. This is a double row technique, which we can see here, and it tore again. So this patient was a very poor candidate, and as would suggest from the data, with all these findings, the chance of a successful repair over time is low. So this was a retear of the suture anchor with proximal of the construct with proximal retraction. And then here's just another failed repair where we can see the tear. In this case, the suture anchors were still intact, This was an extension of the tear next to the suture anchors, where it's no longer functioning, but that was the cause of symptoms. There's the repair, and there's the tear next to it. Okay. Now let's see who's next. I don't know. Shiv?
Okay. So it looks like there's a full thickness tear of the supraspinatus. I see suture anchors.
Yeah. So it's another tear with extravasation of fluid through the. Okay. Good. So what?
Is the Retear post-op normally the construct close to the anchors, or is that where does it happen normally?
It's usually close to the anchors. It's usually, yeah. The anchors, the sutures don't stay around forever. You need biologic healing. If you don't get biologic healing, then eventually the suture anchors will pull out and it will retract, and that's what usually happens. So there is a classification of the post-operative supraspinatus tendon. This is from arthroscopy in 2005. Type 1 is normal thickness and signal intensity. Type 2 is normal thickness with areas of increased signal intensity. Type 3 is thickness with less than a half of normal. Type 4, full thickness interruption on one or two slices, and type 5 is a full thick interruption. I never use this, but there is a classification system like there is for everything. I think it's best to describe it, and most of the time people just want to know whether it's torn or not. But if you want to do research, then you might want to use a classification system like this. So factors associated with a tear after surgery: if you have the tendon itself, the tear is retracted more than 2 centimeters, that's a poor prognosis. The acromial humeral distance is less than 8 millimeters, which would typically be on plain films. On MR scan, you can see the superior migration, and then the degree of fatty atrophy. And what they found is that these two are really independent factors. And the actual degree of fatty atrophy was not an independent factor in this particular paper that was recently published. This is the anterior-posterior dimension of the tear. So according to this paper, the most significant factors predicting poor surgery is superior migration of the humeral head and a tear greater than 2 centimeters in the coronal plane. Let's see. Why don't we stop at this point, and we'll try to pick up and mostly finish the rotator cuff on Thursday. Okay? Any questions? Okay, thanks everyone.
Happy Wednesday.
Yeah.
Dr. Cruz, are you recording all this?